Recording in progress.
Good morning. Shall we wait a few, maybe minutes, a minute or two before opening as people enter the webinar? Good morning, good afternoon. We're 1 minute past. Shall we give it? I mean, we have 18 participants, and I see the numbers increasing. So let's give it another 2 minutes, please. Okay, we're going to start the webinar as more participants log into the session. So good afternoon or good morning to colleagues joining us from different parts of Africa and the world. My name is Binta Sako. I'm a technical officer for the Violence Injury Prevention in the WHO Regional Office for Africa. It is my pleasure to moderate this first session of a series of webinars on burns in childhood in Africa. So I would like to warmly welcome you for this first session of our series. The webinar series is in collaboration with the George Institute for Global Health. And we are partnering in this series with the aim to create a platform for evidence dialogue and collaboration on prevention and care of childhood burns across the African region. Because despite being one of the most devastating injuries affecting children, burns remain largely under-recognized at the global and regional on global and regional platforms and discussions. Yet we know that their impact is profound. Burns injuries are associated not only with high mortality, but also with lifelong disability, stigma, and some significant economic costs for the individual and their families, as well as the health system. Children are particularly vulnerable, and this is why we've focused on this age group. In many settings across Africa, burns occur in domestic environments, and they're often linked to cooking practices, to unsafe housing conditions. Basically, everyday life is one of the risk factors. And these injuries are largely preventable. Next slide, please. I'll take you through the objectives of the whole series first. Today, we will be highlighting the burden of childhood burns and in Africa with some of our eminent specialists, international and on the continent. And in session 2, we'll be sharing some evidence on best practices. We'll then identify gaps in prevention and care, look into the acute, of course, but also long-term care, and we will discuss regional collaboration. We'll have 5 sessions. Next slide, please. We'll have 5 sessions. The dates are here, and you'll be receiving regular updates to be able to log on to each session. That will culminate into the Safety 2026 conference, which is the World Conference on Injury Prevention and Safety promotion. And we hope to take the message that we gather through these discussions with you to Safety 2026. Housekeeping. Next slide, please. Dennis, next slide, please. We have a few housekeeping rules before we begin, and I pass on to the presentations. The webinar will be an hour and a half. We will have some presentations, and then we'll have some time for, we'll have a panel discussion, and then we'll have some time for Q&A. We'll have about a few minutes. So we invite you to include in the Q&A to include all your questions. The Q&A will be monitored by the team. There are many people behind the scenes here who will be looking at the questions, responding, and we'll pick up a few questions from the Q&A when we have that session. You can use the chat if you want to introduce yourself, or if you if you have technical issues with the webinar. Please use the chat for that purpose, and let's use the Q&A only for the questions so that it'll be easier to monitor. We'll be recording and sharing all the presentations and also the recordings with you afterwards. And I think it's now my pleasure to invite Dr. Dennis Mazingi to take you to the first presentation. Dr. Mazingi is a surgeon and global health researcher working at the University of Oxford, Department of Surgical Sciences, and also working at the George Institute for Global Health. His work focuses on injury prevention, pediatric trauma, and burning in low and middle income countries, particularly across Africa. And without further ado, I'd like to hand the floor to Dennis. The floor is yours.
Thank you, Binta. This session, as distinct from the webinar series, this session talks about the burden of injuries in Africa among children. And it's going to be three main parts. The first is we'll speak about the burden from global health estimates. So we'll look at different statistics that are available to give us an idea of how big the problem is. Then we'll look at the role of burn registries and non-fatal data and look at some of those statistics. And then we'll have a panel discussion between myself and other speakers speaking about some of these foundational issues that relate to data, how big the problem is, and how we can improve data. So global burden of burns. So burns are one of the most devastating injuries that any person, but particularly a child, can experience. They cause severe physical trauma, they cause pain, long-term disability, and disfigurement. And most of them occur in everyday household settings, which means that for many people living in parts of the world, burns are kind of ubiquitous. They're something that people live with every day. But many of them are preventable through a raft of simple interventions, and we hope some other newer interventions that we'll hear about a little bit later are very preventable. And this is something that people and children, their families, and societies don't have to go through. However, children face lifelong consequences, so it's not just the acute pain and suffering that is important. The consequences also go beyond just the burn, so beyond the health or medical aspects. It touches on education, social participation, economic opportunity across the life course throughout their entire lives, actually. So it's more than just a health issue. This is really a development imperative. So Africa carries a disproportionately high share of the burden. This justifies our focus on Africa as a continent, um, and children are a large and growing part of that population. In addition, the proximal risk factors in Africa are widespread. So the reasons why people get burns are quite widespread. Access to healthcare for burns is limited, and also there's some significant data gaps that limit our ability to intervene on burns. So you can't intervene on what you can't measure. So in the course of this presentation, we're going to acknowledge some data sources that are out there. The one that we'll be using throughout this presentation is the Global Burden of Disease Study. It's well known to many of us, and it's a big global estimation project that estimates injuries from 204 countries and territories over the time period from 1980 to 2023. And it estimates injuries from what they call fire, heat, and hot substances. So this is an amalgamation of all the different ways that one can be burnt. And that data draws on vital registration, verbal autopsies, household surveys, disease registers when available, and other sources. We also want to acknowledge the WHO Global Health Estimates, which are another type of global estimate, and they're a complementary source of data for national and regional comparisons, and are available across a number of different countries. So I think 192 different countries, and have slightly different data sources. But the latest global health estimates are 2021. So the latest available, most recent internally consistent global assessment is GBD, and that's why we're using the global burden of disease, just acknowledging that there are other sources. So in 2023, globally, there were 150,000 deaths due to burn injuries. And so it might seem on its surface that this is a relatively small number of deaths, especially when you put it up against other causes of death, that major causes of death that are global health priorities. So 1,343,000 deaths for road injuries and 669,000 deaths in malaria. But the real story in burns comes later. 10 million incident cases annually and 10.6 million disability adjusted life years globally. And if we look at how these are distributed across the world, you'll find that Africa is particularly affected. So this is 2023, age standardized deaths in per 100,000 all across the world. And you can see that Africa is particularly affected, whereas other parts of the world have relatively low age standardized death rates. The same is true when you look at DALYs, disability adjusted life years. Africa is again disproportionately affected and justifies our focus on this continent for this webinar and this work. When you look at years of life lost due to disability, an interesting pattern emerges where countries in Latin America tend to now rise to the front. So those people who incur years of life lost due to disability is high in a lot of Latin American countries and one or two African countries as well. If you look at these numbers over time, you'll find that there's been a general decrease in almost all the metrics, okay, since 1990. The black line you see here is the global line, and then these other lines are the different regions of the world classified by their socio-demographic index, and we'll talk a bit about that a bit later. But in summary, age standardized incidence, so this is incidence here, fell by 21.5% globally, So on average, between 1900 and 2023, age standardized mortality fell by 25.3% over the same period. Okay. And then you can see a similar kind of drop with DALYs. What's interesting is what happened around 2020 with COVID-19. There was an increase in deaths and DALYs, and then a decrease directly after that in the post-COVID period. So even though we've seen these relatively modest reductions in incidents, deaths, and DALYs, you'll find that these reductions have not been shared equally among countries based on their social demographic index. It's a measure of development. So when it comes to deaths, countries with a low social demographic index have a higher baseline and have reduced slower than countries at higher social demographic index. So you can see how quickly countries in high social demographic index regions have come down over the years, whereas those in low social demographic index countries have come down relatively slower. And you can see that is true for deaths and DALYs. Of interest is that incidence is actually highest in the high social demographic index, and that's probably a reflection of a mix of the risks that lead to burns in these types of countries. When we split up these trends by continent, you'll find that the African region. So, and that death rate hasn't really reduced much over time. You'll also find that among the lowest age standardized death rates are the Western Pacific region and the region of the Americas. Also note here how wide the confidence intervals are for the data. This is a reflection of the uncertainty in the data available for these estimates. And then you'll find with incidence, as we said before, high social demographic index countries, for example, the region of the Americas, have the highest incidence, but that incidence has been falling rather rapidly over the last few decades. But Africa, third highest in terms of age standardized incidence, has been relatively stable. Remember also that these figures have to do with the completeness of data that is available. So if we consider the disability adjusted life year, you'll find that which is the years of life lived with disability plus the years of life lost due to early death. You'll find that DALYs were predominantly made up of years of life lost due to early death around the world on average in 2023. So on average, health loss due to burns was predominantly because of premature death. Okay, but when you when you break that down from the global figure, and again, we are considering the social demographic index, which, as you can see, is a composite index made of income, fertility, and education. Okay, so 0 is lower amounts of development, whereas 1 is higher amounts of development. You find that the contribution of DALYs attributable to years of life lost due to early death versus years of life lost due to disability differs. Okay, so in high SDI countries in 2023, the health loss due to burns was actually less from years of life lost due to early death and more from years of life lost due to disability. But if you look at low SDI countries, it's predominantly people dying from burns, causing high years of life lost, and then only 17.3% of DALYs in 2023 were due to years of life lost with disability. Okay, so what that means is that deaths are still a major problem, or survivability of burns is a major problem in low SDI countries and becomes decreasingly so as you go up the development spectrum. And you can see here the change in the proportion of YLLs to YLDs over time. Okay, so survivability is going down quite quickly in high SDI countries, and survivability is not going down as quickly in the low SDI countries. So it's gone from 85 to just 82. And you can see that trend here. So you can see that in the low SDI countries, overall DALYs were very high. Most of those DALYs were made up of years of life lost due to early death. But in high SDI countries, relatively low DALYs to begin with have been coming down quite quickly, and at this point are basically 50-50, years of life lost due to early death and years of life lost due to disability. So overall, in 2023, there were 118 118.9 million individuals living with health loss attributable to burn injuries, with a global age standardized prevalence rate of about 1.375 per 100,000 population. This is reflecting a substantial number of individuals around the world experiencing ongoing disability following a non-fatal burn injury. And the story of burns isn't really one about deaths, but burns is a story of survivors. So burns is an example of a condition with a fairly high incident rate, so 10 million incident cases per year, but a relatively small death rate, so 150,000 deaths per year. So you can conceptualize this as a bucket with a high input and relatively low output, okay? We can compare this to other conditions. So, for example, rabies, which is a relatively rare condition, but has a very high mortality. Okay, so the number of deaths per incident case is quite high. And then again, from GBD figures, road injuries with a relatively high incidence, but also relatively higher death rate than for burns. And so they have 2.6 deaths per incident case. So the point here is that because the number of deaths are so low, the number of survivors continues to increase in this bucket. And this bucket represents our health system. It represents the resources we have to devote to taking care of people who have suffered burns. And even if we were to do extremely well in curbing deaths, okay, even if we put a band-aid on our deaths, what that basically means is that we will add 150,000 survivors to this bucket and quickly overwhelm our healthcare system, okay? So in burns, the real story here is the survivors. These are survivors that live with, of course, the acute trauma of having a burn, but also they live with ongoing health loss that then leads to using up resources as well as already overburdened healthcare systems. And when we consider what is important in burns, a recent priority setting exercise asked people from all around the world what they thought should be the priority for global burns research and indeed for global burns activity. And as you can see, the top 10 priorities, most of which relate to the period after a burn has happened. So early burns management, education, complications, scar treatment, anxiety, etc. Prevention only came at number 11, okay? But what the data is telling us is that prevention should actually be front of mind because of that very high number of incident cases, because of that tap that is pouring water into our healthcare system and using up resources. We should put a lot more attention into prevention, into closing these taps, while simultaneously making sure that we do something about the deaths that happen. So it's not a one or the other, but both at the same time. Because if we don't reduce these number of incident cases, we will continue to overburden our healthcare system, use up resources, and have a number of people experiencing ongoing health loss. When we look at age and sex over the life course or burns over the life course, you can see that children are particularly affected. So when it comes to deaths, children are the highest absolute number of cases, but a relatively low age standardized death rate. But as we know from burns, the risk of dying from burns increases as you get older, which is a reflection of physiological reserve. Incidence, however, shows that it's children below the age of 19 in particular, but also young adults who are particularly at risk. So these are the people who are at risk of an incident case of burns. And then when you look at DALYs, when you look at health loss, you find that, again, children are the highest. And then as you go down the life course, there's another peak of health loss in early adulthood, and then a gradually increasing peak in old age. Looking at trends in age and sex, some interesting trends have been uncovered in GBD 2023. In previous iterations of the global burden of disease, females were more likely to have certain things. So, for example, health loss, DALYs, years of life lost, and years of life lived due to disability were higher in females, whereas incidence, deaths, and prevalence were higher in males. But GBD 2023 reveals that at some point there has been a crossover, either because of new availability of better data or a tweak to the model that they used, but now you can see that while males had a higher incidence in earlier years, so this is 1990 to around 2012, since then, females have become higher, although you can see that the confidence intervals cross each other. So not quite sure about whether that's a real change or that's something that is a vagary of the statistics. But you can see the same is true here. Males higher death rate, but in 2023, males dipped below females. And the same is true of prevalence. Males were higher for some time, but now females have outpaced males in a standardized prevalence rate. And you can see the same kinds of things here, except for years of life lived due to disability. So I've talked about social demographic index. It's a widely known, well-used measure of development. And as I said earlier, it puts together fertility rates, income, as well as education. And it's a well-known proxy for development that works across countries. But we were really interested in deprivation as a construct because deprivation tells you about how people live. It tells you about the risks, some of which are particularly important for burns. And so the Multidimensional Poverty Index, or the MPI, is a very interesting index to also explore with this data, this latest GBD data. So the Multidimensional Poverty Index is a measure of poverty, okay? And it's made up of these various deprivations that people experience. Housing quality, and then assets, okay? So we were particularly interested in understanding the relationship with MPI and poverty because that is something that can potentially be we can directly intervene on some of these aspects of the MPI, which we understand are proximate determinants of burn risk. Okay, so we had hypothesized that SDI is suboptimal for measuring the deprivations that are important for burns risk, that countries with the same social demographic index may have very different MPI and therefore very different burn risk. And then MPI would give us targets for intervention. So when you put SDI up against multidimensional poverty, you'll find that there's a relatively linear association at low levels of SDI. But as you get here, you start to see some bunching up. You see here, these red dots are Africa. So Africa is clustered around the low SDI or high MPI region. But over here, among the middle MPI, middle SDI countries, you can see the difference between Mauritania with a relatively high MPI and a country like Nigeria with a relatively low MPI, right? So these are countries with the same social demographic index, okay? So the same level of development, but vastly different levels of multidimensional poverty, and therefore different levels of these deprivations that we talked about, particularly those in the living standards area. Right. And so these are the things that we think are really important for burns prevention when taking a macro view. And therefore, we try to understand what is the burden of burns in that population of people, the MPI poor. So we defined a population of people who are poor according to the Multidimensional Poverty Index, and found that DALY rates for burns are about 3.8 times higher in those who are MPI poor than those who are non-MPI poor. So that's a huge increase in risk for disability. And then death rates are 6.8 times higher in those who are MPI poor than those that are non-MPI poor. So if you remember anything from this presentation, I'd like you to remember these figures here, which is that we should be focusing on those people who are poor as per the Multidimensional Poverty Index, which are people who experience deprivation, in particular in those household types of deprivations. You can also see here the disparity in burns burden among poor and non-poor people. So people experiencing multidimensional poverty, which represent about 1.13 billion people, okay, or 18.0% of the population for which MPI is available, but they account for 45.2% of all DALYs and 59.8% of all deaths, right? So this 18% population accounts for almost half of DALYs and deaths, okay? Whereas the non-poor population relatively smaller. So what does this data generally tell us? tells us that burns remain a major but preventable cause of death and disability. Children in low resource settings carry the highest burden. Survivorship is increasing. Disability is also increasing. Okay. So as mortality falls, and we have had some pretty significant falls in mortality in some parts of the world, that means more people, more children are living with long-term consequences of health burn injuries, and therefore need more resources spent on them, and also put pressure on healthcare systems. Prevention must be prioritized. This data is telling us that prevention is more important than we may have thought. It's really important that we reduce that incidence. So you can see that mortality incidence ratios have changed only marginally on a global level, and improvements in acute care alone will not be enough to reduce that burden. We have to reduce the incidence of burns as well. And also, we found that structural inequality drives burn risk more than general measures of development. So things like unsafe housing, household energy poverty, and limited access to care are underlying drivers of risk and disability, particularly in Africa. And data is the most important part of this presentation, which is that there's limited surveillance in many countries, in particular in African countries. There are wide uncertainty intervals, and there's also low coverage of vital registration data that feed into GBD. So you can see on this map here, this is coverage of vital registration data. So in many countries around the world, they report 90% or more of the deaths that occur in their countries. But in many parts of Africa, either we don't know what the coverage is, or that coverage is less than 75%. And in fact, there's a recent study that came out showing that many countries in Africa have between 30 to 40 um, percent coverage for vital registration. And GBD cannot tell us many of these things here that I think the next presentation will elucidate. And so GBD has its weaknesses, but it also has its strengths. So to build effective prevention and care, Africa needs standardized, comparable data, systematic recording of cause, context, and outcomes, and sustained collection over time. And this is something that registries are uniquely capable of doing. Thank you, Binta.
Thank you so much. Thank you so much. Have you, I didn't cut you off, I hope, too
No,
much.
I'm done.
Okay. So, thank you very much, Dennis. I mean, this was brilliant, and I'm sure all the audiences were captivated by the numbers, but also the meaning that you bring behind those numbers. And it will stay with me. I'm quoting you. Burns is a story of survivors. That's excellent. And as you said, I don't want to take too much time in my transition because we will be having a panel discussion. So I'm sure the audience is thinking about the questions that they have for you, and please put them in the Q&A as we continue the conversation with the role of burns registries in Africa. And I'd like to hand the floor to Professor Stuart Barkley, who is a board certified trauma, burns, and critical care surgeon. Dr. Stewart is an associate professor of surgery at the University of Washington School of Medicine and a researcher in global injury prevention and control, emergency care systems development, and holistic recovery after burns injuries. So we're inviting a highly specialized a person here with us to join our conversation. Over to you, Dr. Stewart.
Thank you, Benton. Dennis, really a privilege to join the webinar. I'm going to expand a little bit on what Dennis said and highlight some of the challenges with the global burden of disease data and where registries, as well as gold standard epidemiological studies, fit into how we understand burn injuries in Africa and globally. So the key messages are first that modeled estimates tell us how big the burn problem is, although I put might in parentheses and we'll dig down why. But registries really can tell us how patients seek care, who gets injured, what the delays are in accessing that care for injury, and some of the outcomes that people experience across their life course. As Dennis highlighted, because of the sparse data across sub-Saharan Africa, some of the real granular information required for injury prevention, resource allocation to health systems, and benchmarking performance, particularly between hospitals and over time, is still something that we are lacking and working on. So, modeled estimates are really important for looking at large geographic trends temporal trends and helping us understand gross burdens. Whereas registries get into the who, the where, the why people are injured, what happens after people are injured, healthcare utilization for things like pre-hospital care, how patients are treated according to known standards of care, and importantly, how they reintegrate back into their communities. There are three lenses of epidemiology, I think, on burn injuries. The first is the gold standard. It's population-based estimates of risk, incidence, access to care, death, and disability. These are typically cluster randomized household surveys and verbal autopsies that get into real detail about what happened around the time of injury, how they sought care, experiences they had regarding care, catastrophic health expenditure, and disability. These have been done in multiple countries in Africa and other countries around the world and really have provided key information that helps us understand the true incidence of burn injury. I mentioned registries are generally used for understanding the flow of patients across the health system after injury and back into their communities. They're generally hospital or facility based, prospective, standardized, and they're very pragmatic, meaning that the information they collect are generally pretty feasible and not very time consuming, are burdensome on the host of the registries, which leads to some lack of granularity compared to the gold standard epidemiologic surveys. But they are vital tools that we use all around the world. They are importantly can signal alarms for changes in epidemiology that can be used for prevention or alerting the government about targeted intervention needs. They define injury patterns that are commonly experienced, which then allows the healthcare system to better prepare itself to meet the challenge that patients require them to face. And then allows for risk-adjusted benchmarking, meaning that we can examine the performance of one hospital compared to another and identify opportunities for quality improvement. And then again, Dennis did a really nice job with an overview of what the modeled estimates from the IHME Global Burden of Disease program as well as the GHE estimates. One of the challenges of these model estimates is that they rely enormously on assumptions, imputation, and very sparse data inputs. The GBD is really accurate for estimating epidemiology of conditions that have been of very high public health and global health importance, for which governments have designed standardized data collection elements for. Yeah, things that are collected at district hospitals and fed up to the health system that are included in death registry, vital statistics data. These are really accurate estimates. Things like maternal mortality or death from childhood bacteremia or watery diarrhea, for instance. For injury and burns, where there hasn't been such a robust and standardized data collection methods for district hospitals or for death registries, there's lots of assumptions and imputations made, lots of relationship assumptions between certain risk factors and injuries, and therefore there's high risk of inaccuracy of these modeled estimates. So the best uses for these are for the population-based epidemiological surveys. It tells us how and why burns are happening, who they're happening to, and can really drill down on very specific prevention priorities. These have really highlighted the importance of cook stove engineering and design, challenges with transitions from traditional to improved cook stoves, and again to liquid propane gas stoves, um, workplace injuries, again, very specific injury problems. Registries again serve for very useful tools for quality improvement, service planning, and benchmarking. And model estimates, I think the real value is in advocacy at a global level. Now, the truth of what epidemiology looks like in burns is somewhat in the middle. And I'm going to say a few things that I don't mean to disparage the Global Burden of Disease program because it's an exceptional program that has really allowed us to advocate for global health priorities with really high quality data given what we have. The challenge is in trauma and burns, we don't have a lot of data from which to make accurate estimates. So what we found is when we do population proportional cluster randomized household surveys and verbal autopsies, the rates of injury that we have identified are about an order of magnitude greater than what's published by the Global Burden of Disease program. So, for instance, in Ghana, we found that there's about 63 per thousand per person years of burn injuries, or about 6.4% of the population. has had a burn injury compared to about 6.3 in the global burden of disease work. So um, the estimates, because the data requires such imputation, it's hard to know where the accuracy is when you look at an entire continent, for instance. Additionally, the model estimates are very sensitive to unmeasured confounding and structural assumptions that go into the data. This is um, the, the figure on the right of the screen comes from part of the GBD data that shows a very unique dip in 2014 and 15, followed by a large rise in 2016 and 17. And we don't really have a clear understanding of what that was from or what it looks like. And providers who are caring for patients with burn injuries didn't recognize that in their clinical practices. I flashed this up at the beginning, and this is another global burden of disease output showing the prevalence of burn injuries under 20% or kind of small to moderate burn injuries. And clearly, this is grossly inaccurate, with Argentina and Chile theoretically having a higher burn prevalence than Sub-Saharan Africa or South Asia, which we know has a much higher burn injury incidence and prevalence than the rest of the world. And this is in part related to the quality of data that gets put into it. Australasia, Argentina and Chile, et cetera, have very high quality registries, and that often leads to less imputation and potentially better measurement. But it comes at the expense of under measuring areas where there aren't great data that is put into the models. So, in part because of this and the importance of getting better quality data for injury prevention, the International Society for Burn Injuries, or the ISBI, and the World Health Organization teamed up to create the Global Burn Registry. The vision of this registry was that it was a minimum data set with a very high value and few data elements that would be feasible to collect at small hospitals and burn centers across the world. The data were thought to be readily ascertainable, meaning they didn't require highly trained registrars or complex data systems to capture. It was centralized at the World Health Organization, which would reduce some of the tech burden on individual hospitals. It allowed for offline storage and online uploading so that hospitals that didn't have consistent electricity or access to the internet could upload data intermittently. And one of the keys is that it was designed for epidemiology, prevention, and benchmarking, not necessarily hospital-based quality improvement initiatives. I'll show you in the next slide the uptake of the GBR and what sort of data has come from it. But the long story short is that it wasn't a very strong implementation over time, and it led to several important publications, but at the same time, not a representative sample of burn injuries across the world. And ultimately, without the tech support and implementation support from the World Health Organization that was sustained over time, it has since been it's not usable currently. We did a study that looked at users and non-users of the Global Burn Registry so that we could consider better ways to reenact and re-implement it. And a few things came up. One is that awareness really, really matters, and we didn't work well enough with regional professional societies to get the information out about the availability of the Global Burn Registry. And the governments we spoke with didn't necessarily prioritize burns independently of other public health conditions. So there wasn't enough demand side pressure on governments to have burn centers include or have burn centers participate in the World Health Organization GBR. Additionally, it was very focused on epidemiology and prevention and not on quality improvement. And while for those of us on this call, epidemiology and prevention is kind of at our hearts and souls, people inputting the data into these registries are at a hospital, and their value for the data, or their vision of value for the data would be how they can improve their hospital functions, how they allocate resources, how they perform compared to other hospitals, and how they trend themselves with specific quality improvement metrics. And when the data don't have that capability, it takes some of the impetus and value away from the hospitals inputting the data, and they're less likely to participate in it over time. The data entry form for the registry was relatively simple, but it was duplicative and not integrated into existing order sets or known platforms used at district hospitals and burn centers. When participants called to ask for support or help or clarification, they often got non-response, which again just is tied to the implementation of the whole program. And then there's lack of facility-specific feedback. The World Health Organization has since rolled out a trauma registry that has done brilliantly, learning some lessons from the experience of the Global Burn Registry. And one of the things that they have enabled is that hospitals can get really detailed facility-specific feedback that helps them make clinical and quality improvement decisions, but also helps the World Health Organization understand the burden of injury globally. This is a couple years, or a few years old now, but it at the same time hasn't changed much since because the registry collapsed afterwards. As you can see, there is very poor representation across many areas of the world and overrepresentation by others, like Iran, who has a really strong national burn registry and committed itself to putting participants into the GBR. But point being, it's this is grossly underrepresentative of what the world's burn problem looks like. That said, there were some kind of key lessons. I combined lessons we learned from the GBR as well as some really important landmark studies that have been done in Africa for the past 10 or so years. And I put down 10 things that we think we know about burn injuries in Africa that, again, play a little bit on what Dennis said, but go into a little bit more detail with some of the registry data. So first, burns are a very concentrated, disproportionate cause of death and disability compared to many other injury patterns. There's about 40 per thousand person lives and person years in sub-Saharan Africa compared to 2 per 1,000 Australasia. That's a very similar number in other high-income countries. So again, more than an order of magnitude difference in just the disability across low and middle-income countries in Africa compared to Australasia, United States, and Europe. It's a fundamentally pediatric problem in Africa. That's not necessarily the case in higher income countries where it's more of an adult problem. I mentioned we found about 63 per thousand child years in Ghana had a burn injury, about 6% of all children with a population proportional cluster randomized household survey and verbal autopsy. Again, our best known evidence type for this sort of problem. Most children are under 5, and they have much higher rate than older children, which Dennis again highlighted. And importantly, scalds and contact injuries in infants and toddlers are the predominant cause of injury versus flames in older children as they get a little more exploratory in their environments. And I think one of the things that the the Global Burn Registry really elucidated that's certainly been seen in other studies is the importance of cooking-related incidents. And I saw in one of the future webinars that you have some of the Design Without Borders folks and some cook stove experts. This is really a key part of how we decrease the global burden of burn injuries as countries transition from traditional open fires like the one in the image to improve cook stoves that are more thermodynamically useful to reduce indoor air pollution, but also could be safer for burn injuries. And then as particularly urban and peri-urban households start to transition toward liquid propane gas stoves, there's lots of opportunities to ensure that they're well regulated and designed to prevent burn injuries, not just to be more thermodynamically efficient and fuel efficient. Interestingly, unsafe cooking arrangements account for about half of all injuries, and cooking outside of the home, meaning outdoors, is not protective if people are still using open fires. So the type of cooking seems to be more important than the location of cooking. There's been lots of concern about people cooking indoors, obviously, again, for indoor air pollution and the risk of children being around extruding flames and hot pots and scalding water. But it doesn't seem to protect women, children, or households if the fire is still open outside. Some of the key risk factors that were mentioned by Dennis are here. I'm not going to repeat them. I think it is really important, though, as we think about informal urban settlements and slum health, the importance of multi-structure fires and how this can be prevented needs to be part of the concept mapping of built environments and how we support households who are in informal settlements. Care seeking is very variable and it's often tied to household education and income. People knowing what to do after they get burned, issues around cooling the burn, first aid practices that may or may not be harmful, and not understanding the importance of The fact that some small burns can be big problems. A contact burn over the knuckles, for instance, that jeopardizes the soft tissue over tendons or joints can lead to significant disability of a hand, for instance, even though it's a very, very small injury. Without the health promotion and the empowerment and the capabilities of children and their families to access or to know they need to access care can certainly lead to preventable disability. Care delays are the norm. The three delay framework holds true of people needing to understand they need care, to accessing transportation to that care, and then when they get there, that care being available, um, all of which have been really well described in multiple countries in sub-Saharan Africa. About a quarter of patients, or a little bit less, use unsafe or potentially dangerous traditional medicine techniques. That was nicely described by a study out of Ghana. Less than half of patients access the hospital in 24 hours, even for major injuries, which is really concerning given that burn shock, which is a common physiological manifestation of a major burn injury, can lead to dehydration, progression of wounds, to being unable to heal by themselves, dehydration, kidney injury, need for renal replacement therapy, and death if they're not adequately treated and resuscitated early, which is often reasons why patients die so early or have significant disability where that was otherwise preventable. And as we know, for other conditions, there's very little use of organized pre-hospital care. Outcomes are also markedly worse than reported by high resource centers, even in sub-Saharan Africa. The LA50, or the body surface area injured, where 50% of patients will die, or the LA50, is between 22 and 39% across many centers in sub-Saharan Africa. Across higher centers in, for instance, South Africa and some places in North Africa and Egypt, the LA50 is in the 60 to 80%, and in Europe and the United States, it's just above 90% now. So lots of important work needed to be done to improve our ability to take care and survive patients with major burn injuries. And then once we survive them, as Dennis mentioned, there's lots to be considered in the health system of how we can reduce their disability and how they reintegrate into their communities. Delayed surgical intervention, sepsis, contractures, and disability occur in about a quarter to half of patients. A lot of this, again, is preventable through improved healthcare functions, which can be detected and improved upon with good registry data. And then, as well described for other injury patterns, the access to coordinated multidisciplinary rehabilitation and community integration approaches 0%, as it hasn't been prioritized by ministries of health across much of the continent. Registries also allow us to look at, identify these signals of conditions that aren't necessarily common, but they're very important. So, for instance, interpersonal violence against women, chemical assault or acid attacks, and self-immolation. Again, these are all very preventable problems. They have been documented across the world, as well as in sub-Saharan Africa. There's really good evidence of what can be done to prevent them. And yet it hasn't been, again, prioritized in large part because they sit under the shadows of global health priorities. There are significant gender disparities and delays to care, as well as even surgical intervention. Again, registries really allow us to say, hey, why are women receiving surgical intervention for their injuries at much lower rates than their male counterparts? Let's track that and see if we can do better for gender equity. There's extremely morbid high voltage electrical injuries that are happening particularly in informal settlements and rapidly urbanizing areas where individuals, often with minimal training and or under protection from gloves and high resistance garments, are exposed to high voltage, which can cause significant cardiopulmonary injury, brain injury, nerve injury, extremity injury, and lead to significant disability despite it not being particularly rare. Sub-Saharan Africa has amongst the highest rates of mass casualty incidents from turned over fuel tankers, people scooping fuel, pipeline incidents in West Africa. Again, all very common things, all very preventable. And registries really allow us to see these important but rare issues. Dennis highlighted a really important finding that burns are becoming more common and have lower survivability in older patients. And this is oftentimes more of a symptom of older age, poor uh, fine motor control, changes in their sensory function, inability to escape dangerous situations, cognitive impairments. So burns become the symptom of frailty, and these patients are very complex to take care of, both in the acute phase and how to reintegrate them safely back into their communities. And there's still a very high incidence of unexploded ordnance affecting civilians, particularly from blast injuries in the Sahel. About 30% of blast injuries have significant burn injuries, and these are often undermanaged given the complexity of multidimensional trauma. Um, Again, registries allow us to identify these problems and to make known what resources they require and how to advocate for them. There are now blast injury registries that are popping up, including in the Sahel, that can help elucidate what these patients need and how we can care for them better. So as we close, there are a few important opportunities for multinational registries that I think we've learned the hard way through the Global Burn Registry experience, as well as participating in other large registries. First is creating a minimal data set that resonates with global users. It has to be effective for the domains that we as injury prevention specialists need it for, but also hospitals must have their um, uh, data collection aligned with what utility and value they see in the information. This is a figure from a systematic review of burn registries across the world. And you can see there's very different rates of inclusion of multiple different domains and locations of the hospital or care system that are included in different registries, which shows us that there's no real consensus on what core data elements need to be present in burn registries. And they certainly vary by intensity of burn care in the health system, but there's certainly some core elements that can be considered, or even a tiered module-based approach to advancing the burn registry from simple to very complex. Next is, I think, burns is a relatively obscure problem for many working in the global health space, despite it being, as mentioned, a significant one for death and disability. It's important for us to graft our cause onto other existing programs and platforms. Again, injury broadly, or road safety specifically, child health. This is predominantly a disease of children. Gender equity, as women and girls are more affected often than young boys and men. So, really important for us to think about how we can leverage existing global health platforms to graft our cause onto. Next is when we do implement these multinational registries, there needs to be a very strong implementation toolkit to prevent people from having frustration with its initial use and then not participating after that. The complexity of doing data collection for registry over a long period of time is not small. It's a quite an ask and a task. So there's been some calls for there being snapshots, or hospitals XYZ collect data for a month and then stop collecting it if it's not part of their routine workflows. Hospitals ABC do the next month, and then you put it all together across a year, and you're able to really understand epidemiology, but without the burden of having to collect data daily for years on end. Being able to leverage mobile phone technology, which is in the hands of almost everyone in healthcare now, regardless of hospital type and national income. So that can certainly be leveraged. There's lots of excitement about how AI can do extraction of information, even on paper with pen and pencils as the data entry mechanism. And then having good tech support that also leverages AI to help troubleshoot challenges with data use and data platforms that might make it a little less onerous on the host providing that support to many hospitals across the world. And then lastly is, hospitals aren't going to do this because they want to out of their goodwill, at least not all of them. There has to be pressure from the global health community, from governments, from ministries of health, from health systems, from hospital leadership to say that burns and injuries are an important part of public health, and we have to figure out how to collect data in a systematic way that then we can use to make better decisions on how to prevent and care for those who are injured. So with that, I thank you for your time and look forward to questions shortly.
Thank you very much, Barclay. Another excellent presentation that complements the first, where we dive deeper into the data. And thanks for your honesty as well in highlighting the gaps and the limitation of the data sources that we have. We'll now enter our discussion segment, where I'll re-invite Dennis to be on the panel, and I'd like to welcome my colleague Caroline Lukatic to the conversation as well. Caroline is a public health researcher and injury epidemiologist. She's currently working with WHO HQ in Geneva, where she supports the development and the implementation of global strategies for preventing unintentional injuries. So welcome to the discussion. We'll have a segment of moderated discussion. Please, after this, we'll open the floor to the audience. So please do include your questions in the Q&A as initially requested. I see some questions coming in, but please go ahead. We'll have some time for the questions. So I hope all the panelists have their cameras. I don't know why I just see Barclay on the.
We all have our cameras, Binta.
Okay, great. Thank you. So I'm going to begin with Dennis. You know, your presentation really highlighted that burns remain one of the most basically neglected injuries in global health. So why do you think this issue is still not receiving the attention it deserves? That would be my first question, because I mean the data is compelling that there's something, that it is a public health threat to people and that something needs to be done. So how do you explain this discrepancy, let's say?
Thanks, Peter. So I think it's probably partly historical, and then partly about other priorities. And then the last part is probably our fault as injury researchers. So the first thing is that, during the 90s, infectious diseases exploded. The HIV pandemic meant that there was a public health emergency that people had to respond to. There was also, the World Bank's system of using league tables that basically ranked diseases according to cost per DALY, and some injuries were unfairly seen as expensive for every DALY averted. You'd have sort of something like burns or injury in general, emergency care, which shares resources across diseases. Some of those resources were attributed to a single disease each time, right? So you end up with injuries falling down on those league tables, and then you end up with them falling down as well on prioritization. At the same time, you have the HIV pandemic. And it looks expensive. It looks like burns units are expensive. They need human resources. They need all these different things. They need infection prevention and control. But what we realized is that injuries, emergency care tends to share resources across everything. And if you are strong on things that make you good at emergency care, you're also strong at many other things. You're resilient in many other health system components. And then the last thing is that, maybe they would have looked at the low number of deaths in certain things, for example, for burns, and thought, not really a big problem. Let's deal with something that's got a big problem. But as we've shown, that the problem is not really about how many deaths there are.
Yeah.
It's about the impact it makes, the continuing impact over the entire life course of someone who's had a burn early on in their life. And
Yeah.
we have to kind of make sure the data is available, right? So you've had years of great HIV, malaria, TB data that perfectly showed the burden. And then you've got injuries and burns, probably only 20 to 30 to 40% coverage of the actual burden. So that burden is hidden. There's also this idea of like an injury, a burn is something that happens to us as opposed to something that is preventable. And so if we continue to make the call that these are highly preventable conditions that we can do something about. It's not like we don't have agency in preventing these. Then I think we'll start to see, yeah.
Yeah, so I think it's competing priorities, but as well as messaging, how we package the information. And as you said, this is about survivors and not about numbers of deaths. So this is really a, interesting approach. We don't hear this often. Another thing that, came to my mind when you were presenting, is about the crossover in terms of sexes. Injuries, it's usually the men when you look at road safety or even drowning. And here you see a crossover. Do you have another explanation than modeling issues to this? Do you think it's a real shift uh, quickly? Because, but
Yeah, I'm
what
not
do you
sure. It's a
think?
very interesting finding, and it's something that I was still trying to kind of figure out. I think maybe it's reflecting some kind of a demographic shift, so women are increasingly not necessarily cooped up at home, particularly in low and middle income countries, and also they are exposed to the same types of things that men are exposed to. Um, so it's possible that that could have been it. When you look at the sources of data on GBD across the years, I'm not sure that there has been a particular source of data that has surfaced. Okay, so it's probably because of some tweak in the model
Okay.
that means that retrospectively some of the data has changed, but I'm not sure.
Yeah.
I would hesitate to speculate because it's such
Okay.
a big kind of change that needs someone to look at very, very carefully.
So we'll follow the GBV data. Let me pass on to Barclay. We heard about the estimates, the modeling, but also real world data through the registries. And I think you really gave us a detailed, explanation on the pros and cons of each. But where do you, if we could summarize in a way, where do you see the strongest agreements between the two data sets, and where do they diverge completely? And what do you think are the biggest blind spots? If you can, some of the audience here are from the Ministry of Health. They work on planning. What are the blind spots that you see in the current understanding of the phenomena around burns?
Yeah, thanks, Binta. I'm gonna blend this question a bit with the question from Blaise Murphy in the Q&A section. I thought it was really insightful that it was asked basically, what we know seems to be relatively useful and clear. Do we believe that there is understanding amongst government decision makers across the continent, and are we doing a good job of transferring this type of knowledge to these stakeholders? And I think your question and this question are exactly related. Um, a colleague of mine who is much more pragmatic, older, and maybe more cynical says, what is it about all this data worry? We understand and generally enough what's happening. We have a translation and an implementation problem, not a data problem. And I think there's certainly both. We have to kind of raise the boat altogether, but there's certainly a lack of information given to decision makers related to burns and trauma, burns and injuries that is readily actionable. And we liken it to not having granular data, but at the same time, I mean, as you just mentioned, w women in most low-income and middle-income countries have a higher incidence of burn injuries than men, and that's in large part due to their proximity to unsafe cooking arrangements compared to to other settings. So, I mean, that in itself, with children exposed to the same issue, we understand why the majority of burn injuries in the world happen. The specific details from each location about what engineering or behavioral or health promotion strategy must be followed is certainly what's important on a granular level. But in general, there's enough information that we can provide more clear, translated evidence to policymakers so that they can use it to make decisions for the population. And we have to have a little bit more implementation mindset about once we find that policy window, when you have a decision maker wanting to invest in burn injury prevention, we have to be able to demonstrate, well, this is how you do it, and this is what you need, this is how much it's going to cost, and here's where you can access it. And until we package that in a really nice, understandable, ready way, when we have the opportunity to influence burn injury prevention via that policy window, we're not going to be able to do it in a timely fashion. So, yes, data is a problem, and we aren't translating it well, and we're not providing an implementation ready process to really intervene on it.
Okay, thanks. So we need to be more practical and respond to the needs of the countries to implement. So a technical package on burns. Caroline, I'll bring you in as WHO here. Um, uh, yeah, you Bartley mentioned the WHO registry, and he did already highlight a few of the challenges that the registry faced. Now, as WHO, what do you think would be the role of WHO regarding such a registry? And just going on to Barclay's question around, okay, the data is flawed, but what can we still do? There are things that we can do. How can we support countries to actually implement something? So if you can, come in and discuss a bit the role, but also the practical elements that we can bring to countries to make a shift and that, they survive and thrive, those who are victims of burns. Over to you, Caroline.
Thank you so much, Binta. And Barclay had a really fantastic series of slides that presented opportunities and ideas for expanding or moving this global burn registry forward. I think from our end, again, as Barclay has mentioned, it was a very resource intensive endeavor, particularly having this standalone. And I think there were so many lessons learned. The ones that really stuck out to me was this need for greater investment of the people actually supplying the data, having them understand what the benefit of collating and reporting this data could be. Really critically, the integration of the data collection into existing systems and facilities. I think, again, there are so many rich and important lessons learned through this process. And I wonder whether there's actually scope to consider the initial rollout of Global Burns Registry as almost a pilot. Because I think, again, there is a lot of strong ideas for a way forward, and things that are very relevant and recent, like the application of AI to do some of the data extraction and the mobile technology available now to health workers. I think it's a very exciting and opportunistic time to be revisiting this as a concept. Again, I think just to be realistic, with this sort of model of the Global Burns Registry, I don't necessarily believe that one day we'll be able to give us a perfect global picture of the burden of burns. Again, it's very much opt-in, it's voluntary contributions from specific health facilities. But I think that the information it does present, that additional context around how the burn injury occurred, to whom, why, under what circumstances, that is so critical for informing how we develop our prevention efforts. I also wanted to note that systems like the Global Burn Registry, yes, they operate through facilities, health facilities. So we're assuming that the people who access these facilities have the ability to be there, recognize the severity of the injury, and have the empowerment to be able to go and request that care, and the financial ability to go and request that care. So I do think there is some scope to investigate more around the impact of burns at community settings. Again, I'm not going to say we're going to have a great, beautiful national, let alone regional or global data set from this. But I want to just go back and reiterate this importance of leveraging existing systems that are already in community settings. We collect injury data, again, very much at that micro community level, but we leverage healthcare workers who are working in community settings to do routine health screenings in households. There is an opportunity, again, for WHO to look at developing a set of basic indicators to be able to track and monitor exactly what's happening in those communities. We're not going to get a representative sample from this type of work, but again, it can give us a really good sense of what is happening and what could be done to really target specific prevention approaches.
Thanks, Caroline. I see Barclay, you have your hand raised. Did you want to come in as well to complement what she's saying?
Yeah, exactly. And one of the things that Caroline mentioned that really resonated with to me the what policymakers can really focus on. When we think burn injuries, at least those of us in the clinical sphere, we think of our patients that have had huge burn injuries that take off years of our lives as we try to help them get through their devastating injury. But the majority of these injuries are small and they're very survivable, and the disability can be readily prevented. The WHO has done a great job improving and strengthening its early trauma and burn care resources so that patients get good care in the first days. The International Society for Burn Injuries has guidelines on how to care for patients in the days and weeks thereafter. And the community-based health worker focused disability prevention training and community-based rehabilitation trainings that WHO has can all be kind of packaged into one concept for preventing very um, simple burn problems that can be solved with good wound care and splinting, early excisions and grafting, which can be done as one of the essential trauma care operations at first level hospitals without having to do this very complex, expensive burn care. That's 90% of what we're talking about. So the solutions do exist for most. Moving the needle on big burn injuries is a whole different
Yeah.
ball game, so to speak, than it is making sure that children and young people and women injured don't have disability from very preventable problems that are not expensive to take care of, and that there are great WHO resources for, and community health workers who can really make a big impact on how rehabilitation and recovery happens in people's communities.
Yeah, thanks for this. And throughout the series, we will be talking about the acute care and the long-term care and rehabilitation. But as you say, there are simple solutions. It's about packaging them together and making sure that we coordinate even within the health community, basically. I see Dennis. Dennis, you want to come in?
Just quickly, two things that I think echo exactly what has been said about how we can improve registry usage. The first is using existing systems, the data systems. In my own work, we found, so if you look at the last decade, especially on the African continent, there have been a proliferation of data protection and data sovereignty laws that have been enacted one by one across nations with varying degrees of stringency. And that's something that is actually very important to governments is what data is generated, who has access to it, and who has control over it. And so if we can integrate with existing data systems, many of which are proprietary and in specific countries, then it will increase the how comfortable governments are having this data generated. The second thing was about creating demand side pressure. So it's about us being really increasing the utility of this data, right? And doing that,
You're frozen.
everything
Yeah.
from young trainee doctors who need to um uh to document cases for their logbooks, to hospital administrators who need audit data and helping them to actually surface that data and let it do important things, to policymakers, giving them a dashboard that they can see and then actually showing them, writing policy briefs and saying, this is what, if you do this, this will happen. And improving that utility, you'll find that people will start, using it themselves because of that utility is just so high. Because I think as scientists, we tend to think like data is always important, data is always nice, always more. But if we can just take bite-sized pieces of it, package it in a way that is for a very specific stakeholder, and just give it to them and say, this is what you could possibly do, then that could be very interesting.
Thanks, Dennis. This is a really interesting conversation that is going to be coming to an end. But before I'd like to ask all of you to give me, but really one concrete action to reduce childhood burns in, let's say, a random African country. You're speaking to an African policymaker, and we talked about packaging the message. So that's your assignment. It has to be a clear message to a policymaker in Africa on how he can improve the burns care, prevention and care. So I'll begin with you, Dennis, if you
Yeah.
don't mind.
So
You're the one I see.
I'm going to speak about a specific area where we've worked before. I'm talking about peri-urban areas or urban areas in Uganda, Kampala, places like Kisenyi, Kasubi. My one recommendation to governments, local and national, is to formalize those settlements, electrify those settlements, and put water through those settlements. Because if you change those very specific things, basically, and obviously we've got to do that very carefully, but no, people won't need to necessarily use charcoal stoves outside in the front of the stoop anymore. They move on to different types, different forms of cooking. And of course, we have to make sure that development can have unintended bad consequences as well. So we have to make sure that as they make the transition, that we make sure that it's safe. We make sure the regulations keep pace. But yeah, electrify and water reticulation and formalized settlements that are in the middle of the city but informal at the moment.
Thank you. So a surgeon who's recommending the determinants of health. This is great. This is great. So over to you, Caroline. What would you tell a policymaker?
Right. Well, I actually think, Binta, we have a bit of homework before we approach the policymaker as a sort of global burns prevention community. And this is sort of a learning I've had from approaching policymakers with other injury prevention topics. And it goes back to what Barclay was saying. We need to really find the overarching cross-cutting agendas that burns prevention and management feeds into before we start having conversations with government representatives. I don't think we can afford to, in our current climate and in the current sort of situation the world is in, to address this as a vertical program. We need to be approaching this as a much more broader, multi-sectoral, sustained idea. And again, Barclay mentioned a couple of agendas. I can also think of workplace safety, which is also applicable to children in many African countries. I can think about safe and affordable housing. I can think of response to mass casualty events. There are all these other types of hooks that we can start to pull and draw and do our thinking around prior to suggesting really vertical interventions. So I think that's going to be the critical linchpin for sustainability and wide scale of interventions. Thanks.
So integration, multi-sectoral integration of the agenda. That's great. And now, Barclay?
Mine's much more pedestrian than Caroline's eloquent explanation. And it's an imperial measure, so I apologize for that, but I'm sure it could be adaptable. I'd say school-based education and community-based health promotion focused on the concept of 3 feet, no heat for children, giving space around cook stoves, particularly those that are on the ground or within reach of children under 5, which are, again, the majority of burn injuries happening in sub-Saharan Africa.
Thank you. Thank you so much. I don't know if everybody can give a round of applause to our panelists through emojis, but I think this has been a really interesting and enlightening conversation that we hope to continue. I will take now so please stay on the panel because I'll take some time. We have 7 minutes for a Q&A. I don't know if there have been additional questions in the Q&A box. There was a question from Blaise Murphy, but that has already been responded to. Blaise, did you want maybe to unmute and ask for further clarification to your question or a follow-up? Because for now, I don't have additional questions. I think there's I can read there are a few comments in the chat. Great point to Barclay. It's for you. The morbidity from small burn injuries is a very important topic and carries economic impact worldwide. Prevention of secondary and tertiary problems from burn injury are very important topic for prevention and intervention. So, highlighting what you were saying about the easy wins, the low-hanging fruits, and more important topics further on. So, if there are no questions, I guess that means everything was very clear.
Just wanted to say, Binta, that I think there may be an idea that as economies get better, as countries develop, these problems will disappear because people will do better. They'll start using different types of cooking methods, and then they'll come out of poverty, and therefore some of these diseases go down. And we've seen, examples of this trend with TB, for example. A lot of the reduction is just because of, but I think this is not true for things like burns. I think as development goes up, especially if we take an SDI approach to development, where we just say, GDP per capita going up, great. Because what you end up with is increasing income inequality, rise in the urban poor. They continue to deteriorate on those specific key deprivations, even though on average, the country seems to be getting more prosperous. And actually what you might see is a paradoxical increase in burns and other types of things you can get in urban areas. And so if we shouldn't just be thinking about development of poor countries, but we need to be thinking about those specific deprivations. Can we make sure people are living in better housing? Can we reduce electrification poverty? Can we make sure people have clean water? All of those things, and then the poverty rate can decline as well as the development rate going up. And I think we saw in one of my slides that yeah, you can have the same SDI level, but you can have vastly different levels of poverty, and that's what our focus should be. It should be on people who experience deprivations that lead to risk.
Yeah, absolutely. You're unpacking the nuance of poverty, basically. This is really, really important. So, I think we had a very good conversation, and we will now begin to wrap up. The session was really very informative in giving us the burden. So we now know the numbers, but we know the limitations of the numbers as well, and the different forms of data. I hope we will be sharing the presentation, so you'll be able to dig deeper into what Barclay and also Dennis really presented to us. It's very rich in information. And what you just mentioned, the multi dimensions of poverty and how poverty affects burns will be further discussed. I think we've unpacked different elements without going deep into it. We've unpacked different elements of the discussions that will be coming. So here we're giving you a bit of time for you to scan the link to the next session, where we'll be talking about the risk factors and the safe environments. And we really welcome you, and also bring along your colleagues and friends, those interested in this thematic. I think we'll be able to unpack even more around burns in childhood. So I'll just give you some time to scan this, and we'll also have it on our LinkedIn, and we'll also put it up in we'll share by email to the list of those who have registered. We'd also like you to give us some evaluation. These evaluations are really helpful in shaping future webinars, and really looking at what is needed from your end to make these more informative and more useful, because it's all about making sure that we're practical and that we give you the tools to be able to act in your respective countries. So by shaping webinars that really resonate with you, it will be great. And as I said, we'll be sharing all the materials with you later on. So on this note, we're right on time. I'd like to thank you all for your participation. I'd like to give a big thank you to the panelists, who really brought a lot of expertise and insight, and were able to unpack this theme in less medical terms, I would say, highlighting really the importance of that environment, and how it shapes how social determinants of health, the poverty, housing condition, urban settlements all play a role. And if you'll notice, most of the speakers did put upfront those kind of changes to have an impact. So thank you very much to everyone, to all the participants who took time to register and participate. We look forward to seeing you in a month. Thank you very much.